Good afternoon, everybody. So on behalf of Department of Surgical Oncology, I welcome you all for this CGR session. This is on a very pertinent and probably one of the most important public health burden in terms of the cancer, breast cancer, which accounts for almost 1/4 of the total cancers in women. And as it happens is that what starts in breast cancer essentially is either followed up or taken forward for other cancers as well. And that is the history over last 3 or 4 decades. Same we are also experiencing, and that's what we are going to talk about, that how the things have changed remarkably. And many of the senior people who are sitting here when we were training, things are completely different what was at that time. The good thing is that this has got so many lessons to learn, as well as the scope for fine-tuning our practices. And the breast cancer history is now essentially a story of what started with complete radical mastectomy, and now we are also thinking where to intervene in axilla, if at all or not. So Dr. Astos, who is lead surgeon for our breast program, he will be talking about the part of the and the background of this journey. Dr. Jyotisman, who is heading the breast program in NCI Jhajjar, will also be contributing his perspective regarding the new center when we started that. So I'll hand over to Dr. Astos to start with the CGR session.
Thank you so much, sir. And respected esteemed faculty and all my dear colleagues. So currently, if we see the global data, so in India, around 2.3 lakhs patients we are seeing every year, and there are almost 1 lakh deaths. And this is contributing to 9.7% of global breast cancer cases. And if we see from 1990 until today, so in every decades, the numbers are doubling. And by 2040, this is around going to be 4 lakhs. So if we see the evolution of breast surgery, so what was the status in 1990? Radiation oncology was established, medical oncology, it was growing, surgical oncology mostly being done by general surgeons, no subspecialty of breast surgery. There was mammo, USG, FNAC, core biopsy was not established, and ERP are not widely available. Surgery, only mastectomy was the choice, and systemic therapy, CMF and tamoxifen. As a RT tool, there were cobalt machines and very few Linux. There was no PET, no MRI. Currently, there is a lot of. So this is just a timeline of AIIMS New Delhi, started in 1990. And over the period of time, we grew and we developed a lot of things, and we'll see over the period in our upcoming slides. So breast cancer surgery, it's about the mutilation to minimizations. And now the oncoplastic era, then extreme conservation. Now we are thinking about the robotic breast surgeries and doing robotic breast surgeries. Now currently the main focus is on the de-escalation of axillary and local therapy. Currently we are focusing more on the biology-oriented treatment, personalized treatment, and the data maintenance. So this was the trend in our institute. Around, we have done 10,171 breast surgeries over the period of 3 decades. Out of these, around 30% are now breast conserving surgeries, and we are doing implant-based reconstruction, more than 130 cases, robotic mastectomies, and type 2 oncoplasty, including perforator flaps, around 300. So this was the Halstidian era when we are addressing entire axilla, chest wall, and then modified radical mastectomy. So era has gone changed. For 100 years, there was the Halstidian mastectomy, and then subsequently around 2000 BCT concept, now there is a personalized treatment. And 2020 onwards, now we are thinking of extreme conservations by doing different procedures. So breast, it's a symbol of femininity, attractiveness, and motherhood. And morbidities of mastectomy, definitely loss of feminine attractiveness, altered body image perception, psychosexual problems, painful reminder of cancer, and depression. So these are all very important things. So if we see in the phase 1, in between 1990 to 2005, So in 1970, Bernard Fisher is the guy who first done the first trial about the radicality of the treatment, and they established that mastectomy and radiation will be suffice. So we moved towards the less radical approach, and then subsequently BCT as a treatment modality by NSABP06 trial. So Halsteadian era, still in 1990s, we were seeing such kind of cases. Even today only we saw the cases. And for these cases to address, we have devised this TA flap, thoracoabdominal flap at least, and we published our data over thoracoabdominal flap first in 2004, then subsequently recently. So there are a lot of studies after that, and BCT has been established as a treatment modality in early breast cancer. So this is how, from radical mastectomy, we have gone towards the breast-conserving therapy. And as necessity is the mother of invention, in our department also, we focused on BCT because there was less bed, so we are focusing on the day-to-day surgeries as well. So the entire this period was dedicated to breast oncology services. It is multidisciplinary coordination because this is the era surgery treatment was not the suffice. So important role of radiation oncology, then medical oncology, pathology, and all come together on board. So if you see for planning a one breast conserving surgery, you have to be on board with your radiologist, with your medical oncologist, radiation oncologist, intraoperative frozen section, IHC marker. So it's a huge teamwork, and the very seamless flow of the orchestra is needed. So now I request Dr. Suren Saini.
Thank you, Dr. Astos. As the surgical oncology moved from the radicality to the precision, radiation oncology accompanied the surgical oncology in delivering the modern treatment. Initially, it was only 11.3% of the patient, of early breast cancer patient, who were offered breast conservative surgery in the last decade of the last century. But the RT infrastructure that time was already established, and radiation oncology helped to establish the breast conservative surgery program there. In the first decade of this century, when IRCS Sentinel lymph node program matured, at the same time also the radiation oncology provided de-escalated radiation approaches. During that time also, department SDR brachytherapy expertise extend toward the APBI also. And in last 10 years, when the BCS rate increased to 40%, we continued as a radiation oncologist or radiation oncology department providing the de-escalation approach. And during same time, we are also offering the implant sparing RT integrated in their reconstructive planning. So initially it was cobalt-60 therapy, 2D planning, wide margins, limited conformability, dominated IRCH practice through the phase 1, 20-30 years before. But migration to the linear accelerator brought 3D CRT and image guidance, enabling every de-escalation step that followed. The clinical difference shows in the patient, crude field, skin dose limitation, often produced marked toxicity and poor cosmesis in the third diagram. While with the modern conformal RT, now delivers comparable tumor control with substantially better cosmetic outcome. The last diagram we can see that was treated by the APBI, and we can see or appreciate the cosmesis in that patient. Initial regimen was 5-week regimen, 50 gray in 25 fraction, and now we are delivering 26 gray in 5 fraction if radiation is indicated to the whole breast only, and we are now exploring this 26 gray in 5 fraction to the regional nodal irradiation also. Now come to the APBI, that is quite important for the cosmesis in BCS patients. The department gained substantial experience in last 15 to 20 years in APBI. Initially, it was 35 gray in 10 fraction interstitial brachytherapy. And in last 10 years, we developed a new regimen, 28 gray in 5 fraction by APBI. This new regimen is comparable in terms of the acute toxicity, breast cosmesis, and IBTR rates. And in last 5 years, we are working on very accelerated partial breast irradiation that is delivered in 2 days only in 4 fraction. and the acute toxicity with this regimen is quite low, and breast cosmesis is good to excellent in more than 90% of the patient. This APBI we are also now trying to explore in the post-NACT early breast cancer patients. Now come to the important aspect, restoration, the implant sparing RT. The many patients of locally advanced disease, young patients are now offered with the implant, with the nipple sparing mastectomy and with implant based reconstruction. In these patients, because these patients are quite young, whole breast irradiation is required. So that may cause capsular contracture 2 to 4 times more than those who are not receiving RT. So the implant sparing RT, we deliver only the, we give a risk adapted approach. We can see how it look like the implant sparing RT. We can see this young patient with the nipple sparing mastectomy and with implant. The disease was laterally, so we delineate the volume laterally only, and we delivered, and there was very good cosmetic outcome in such kind of patient. This whole process is quite rigorous, but not less treatment, but smart treatment. Thank you. Now for the pathology perspective.
So, truly speaking, if you are doing a good quality of breast conserving surgery, and if your radiation oncology colleagues are not on board, definitely the results are going to be horrible. So it's very important planning and dose creations. Then only for a good breast conservation program, the involvement of radiation oncology colleague since day one is very important. So now I request Professor Mathur, sir.
So let me give you some idea about how pathology has evolved over the years. And I've been here since 1999 as a senior resident, and I have seen a lot of sea of changes in that era. Not as early as this, but definitely up 99 onwards, I'm witness to all the changes which have occurred in this department. So earlier, in the very early days of this era, we had FNACs and needle biopsies, which both used to be done. So FNAC was being significantly used for primary diagnosis of breast cancer, and it was not so uncommon to get maybe 8 to 10 FNA diagnosed breast cancers a day in FNAC clinic. I myself have done so many FNAs of breast cancer patients. Now you'll see interestingly how that has completely changed as of now. We used a simple morphology. As I have titled, this is a morphology only era. Sorry, that was dwarfed by this picture. So it was classified into histologic type. We are having the 5th edition of WHO. So I'm talking about WHO's 2nd edition, which was classified into some basic histologic types. So we used to give the diagnosis, invasive carcinoma of the breast, like that. Any term was used. There was no specific as a defined terminology. Then grading was also done. By that time, that Bloom-Richardson grading was also existing. Then came the WHO 3rd edition, which began transition. There were some recognized this genomic integration of the classification was talked about in this edition. There was no definite WHO defined TNM staging at that time as it exists now. Then talking about the next phase, this is the 2006 to 15 phase. This is the era in which, some major changes happened. Now, even in this era, I would say a lot of FNA was still being done. Now, frozen section started picking up for sentinel lymph nodes, margin assessment in this phase. And I remember a lot of Dr. Rajendra, Dr. Seenu, Chumbar sir, they used to do a lot of these kind of surgeries in this era. So we had typically Dr. Seenu, Dr. Rajendra, these are the faculty who used to do a lot of breast surgery. I had a fortunate of closely interacting with them. And that is how actually I developed interest in breast cancer, so as to say, and thereby once somebody develops an interest, then you start working towards bringing about the changes in that particular thing. So that receptor reporting was started in this era, but there was no, it was kind of the reporting protocols like ALRED scoring, HER2/neu specific guidelines, they were not specifically defined even globally at that time. So it was as if, institutional driven, not specific. Then the guidelines came. The HER2/neu guideline came in first in 2007. ERPR guideline reporting came in 2010. So since then onwards, the specific protocols for reporting, scoring of these markers was done In-house ERPR HER2/neu in our department was started first in 2005. This interestingly happened because of the IRCH funds. Still remember a fund of rupees 5 lakh was given to the department, transferred to procure this ERPR2. So you can imagine 5 lakh at that time may have been a significant amount, but not enough to last more than a year or 6 to 8 months, I think. So we did it for some time, but then there was some administrative issues between the two departments and it stopped completely. So it was discontinued for a long time after that. And so now in this era also the NACT receiving the increase. We did initially only the Miller-Payne scoring to assess the NACT response. Another thing about the same era is that the core needle biopsy, now the phase 3. Now the core needle biopsy became the mainstream, and gradually I have seen the FNACs completely disappeared from the scene, and now it is almost every case is diagnosed as a core needle biopsy. We started doing triaging of core needle. We realized that these breast cores are very precious, so we divide them into 2 blocks or something so that, in one go, tissue is not wasted completely, only the initial workup. We have something because patients come to us later with recurrences. Pre-analytics were paid attention to, the cold ischemia time, duration of fixation. Whenever we encountered any deviations, we informed our clinicians. SOPs for fixation and grossing were well established. We had standardized grossing protocols for sections, how many sections to be taken. Everything is now defined. Specialized tissue processing protocol. This is very interesting because we realized breast is a very fatty tissue, and if you run them in a routine processing, they don't get fixed well. So we have now a separate lab, which is a processor which is dedicated to breast cancer specimens so that we get good quality slides and blocks. Another aspect of this is the advent of immunohistochemistry. There's a lot of advancement which has occurred in IHC. We initially had the semi-automated and auto. So from manual, we moved to semi-automated and automated. Now we have the Ventana platform. We do ERPR, HER2/neu, Ki-67 in all breast cancer core biopsies. It serves as a surrogate for molecular classification, luminal A, B, HER2/neu enriched, etc. We now strictly follow these LRED and HER2/neu scoring system. We also have a vast array of IHC panel for subtyping whenever required for special subtypes of breast cancer. We also adopted this reporting of low ER, HER2/neu low and ultra-low wherever required. PDL1 testing was initially being done. Now it is not so frequently done because I don't think it is being followed so much. But then whenever required, we offer this PDL1 testing as well. Frozen surfaces, SLNs and margins became more frequent as BCS kind of surgeries increase. We also witness more screen-detected lesions, especially from the surgery side, where they are picking up early lesions and biopsying them or doing a WAB on them. TIL assessment has also now in this era became a part of routine report as such. Another important change which happened in 2019, we started offering services for FISH for equivocal HER2/neu testing. So we have till now done almost 1500 HER2/neu FISH in our department alone. PIK3CA mutation testing was started in 2021. BRCA1 and 2 testing, we have done around 100 cases in 2025. We plan to do it on a regular basis in the coming, in this year and the coming subsequent years also. So with the advancement of radiology, we had special requirements like clip localization, multicentric tumors. These were detected more often. So at the time of grossing, all this information needed to be paid attention to so that specific sections could be taken. We had mapping of NACT specimens, the tumor bed, how each was mapped and grossed in a very systematic manner to assess the chemo response score. Both RCB, the residual cancer burden score by MD Anderson and Miller-Payne, are now reported in our reports. We had the synoptic reporting, handling reviews and follow-up requests is another major task with breast cancer. So breast cancer is huge in our institute, combining surgery, IRCH, NCI. It is a heavy load on pathology, and we try to do our best to meet the global standards as far as possible, given the limitations. But and this is a very important part. There are only 24 hours in a given day. We can't have dedicated meetings for but we have very active WhatsApp groups on which we interact, these review requests. There are a lot of to and fro information which is required even after issuing of the final report. So that is something we keep interacting with NCI, with RACH, with surgery units, or whoever does breast cancer management. So all these things regarding breast keep us very, very busy in pathology. So thank you very much. That's what I wanted to give you an idea about.
Thank you, sir. So with the introduction of molecular markers, actually currently we are able to make decisions prior to the initiation of treatment, whether we are able to preserve this breast, we can restore, and we can take the provisional treatment planning. So this is how pathology is also helping in the conservation of breast. I request Dr. Jyotishma for
Thank you, sir. Respected teachers and colleagues. So, coming to the sentinel lymph node has also gone over a long change in treatment and protocols. So, if we start, see from 1990s and in the last that decade, so there were multi-center trials, and last series has confirmed that sentinel lymph node has been proven to be superior to doing a standard, it has become a standard of care, and from compared to the axillary lymph node dissection. And so in like 2006, there is the Varanasi et al. There's the randomized trial where they have shown the outcomes between sentinel lymph node and ALND, and that's how sentinel lymph node has come into the picture of breast conservation surgery and breast cancer overall. So here in our center, like in India, we do not have that blue dye and gamma probe. That was quite long time that we have limited training facilities. So at our institute, we have custom made isosulfan blue and intraoperative imprint cytology to supplement this sentinel lymph node to do the sentinel lymph nodes, and sequel is supported by pathology, as Mathusa already has told about. So based on this, we have published our results on imprint cytology, the initial validation studies, and which have got good reviews. Overall, in the last 3 decades, we have analyzed our lymph node ratio in breast cancer, and this is what we have published some time back, and where we figured out it's around 4,000 patients, where we found that lymph node ratio is predicting more to survival overall and disease-free survival. So coming down in 2005 to 15, so we have started doing breast conservation surgeries at our center with expansion of radiological services. So more IHC markers, increase in neoadjuvant therapy, the rates of breast conservation have increased. As our population is more of a advanced cases, like T4 patients are more, so neoadjuvant has also started to play a big role. So if you see the trends in this few years, the locally advanced cases have started to come down. It is becoming narrowing. More of early breast cancers are coming up in our centers, and overall, this is what is similar to the national trend. And falling in parallel to this is the mastectomy rates, where the BCS rates have increased gradually over these years. And this is what we can see at our center, how the BCS rates increased from the 1990s to now. And many of this is supported by the good results of neoadjuvant therapy, as our medical colleague will describe. So the upfront cases and the BCS post neoadjuvant has also started to increase quite a bit over the last 10 years. So this is the curve which is showing the BCS rates after neoadjuvant therapy and also upfront cases. So both are picking up, and obviously this T4 and those patients, a lot of these patients are having good response to neoadjuvant therapy, which is helping to increase the rates of BCS, and also supported by the non-palpable lesion localization by wire-guided localization and ultrasound localizations. So our radiology team has went hand in hand in helping this lesions where tumor completely is going down and not becoming palpable. And so axillary staging, similarly, this as sentinel lymph node rates have significantly increased over last 10 to 15 years. And we are currently using the methylene blue on the ICG, which is widely getting used, and also gamma tracers. And similar to that, the ALND rates have also fall down. So this is the plots showing the these results of the SLNB versus ALND. So if we come to breast conservation, so these are the conservations which were done in the pre-oncoplasty era. So these are the quality of construction. It was could not be. It was not considered important, and also the techniques were not developed. Obviously, with time, these techniques have started to develop, and that is what is the current recommendation. So is a volume of less than 20%. There's simple oncoplasty, and more than 20%, there's complex oncoplasties come into play. Of course, it's supported by the different type of perforator flaps. So the father of oncoplastic surgery, who was described the different types of breast conservation, keeping cosmesis in account, and also along with the oncological outcomes. So this is one of the landmark papers where this classification has been described based on the different type of resection, volume resections, and the type of oncoplasties that is required. So these are standard steps. So obviously this is a bird's eye view, but there are a wide range of type of resections are required. And so this is a overview of the different type of incisions and different type of resections which can be done based on the quadrant by quadrant. And this is another atlas. This all our contributions started from the Dr. Cloud, and so here we go. So this is all about. So I welcome the medical oncology teams.
Yeah. So thank you, Dr. Jyotish. And this last slide that we have seen. So most of the still 90% of the breast oncoplasty is the level 1. So out of 100 cases, still 90% we are doing with simple mobilization and getting good outcomes. So it's not every patient is fit for the volume replacement or perforator flaps. This is very important. I am very grateful to medical oncology colleagues and seniors. I request Dr. Atul Batra for his perspective regarding breast conservation.
Thank you, Dr. Ashutosh. And, I think one thing that has revolutionized the management of breast cancer is understanding that it is not one disease. The earlier trials, if you look at, were all including all kinds of breast cancer. All patients were exposed to adjuvant chemotherapy, tamoxifen, AI, and we saw that all patients would receive CMF earlier. And then this evolved to include anthracycline, taxanes. But the major understanding change was that this is not one disease. And this is where Dr. Mathur comes to our gracious help in diagnosing and classifying this disease. Clinically, we would classify it as ER positive, either luminal A or B, HER2 positive and triple negatives. And with this understanding, the whole concept has changed. The neoadjuvant chemotherapy, which was earlier used only for patients, those who are inoperable, locally advanced breast cancer, has now come into picture even for early breast cancer. This has been possible because of the understanding that the disease biology is very different for triple negative vis-a-vis HER2 positive breast cancer. For example, in triple negative breast cancer, with patients who have a tumor size of more than 1 centimeter, or 2 centimeter tumor size, would also undergo a neoadjuvant chemotherapy at this point of time. This was not so earlier. And for an ER positive tumor, this patient would be selected for an operant surgery. Now, the backbone of neoadjuvant chemotherapy over the years and decades has stayed practically the same. Anthracyclines and taxanes still form the backbone. The controversy over carboplatin still goes on. And triple negative is the most responsive subtype. We see that objective response rates are nearly 90%, and only around 3 to 5% would have primary progression during neoadjuvant chemotherapy. The latest addition here has been the inclusion of immunotherapy, which is pembrolizumab, where we ask Dr. Mathur to conduct the PDL1 in metastatic setting. In neoadjuvant, all patients would be offered, which is currently a little less accessible, which led us to do a clinical trial as well, which was published and is now currently accepted as a standard of care as well at much lower doses. This has also significantly led to an improvement in survival as well. Likewise, HER2 positive breast cancer, even if the patient has a smaller operable tumor, even these patients would undergo neoadjuvant chemotherapy first. Now, this gives us a chance to see the biology and chemosensitivity, the sensitivity to the therapy that has been given earlier. So if the patient achieves a complete pathological response, that is, there's no tumor in the surgical specimen, and mind you, this would happen around 50 to 60% of times in triple negative as well as HER2 positive cancer. So there would be no tumor, and these patients tend to do extremely well. This gives us as a prognostic marker as well as a predictive marker. Now, predictive, because if this is not achieved, you can change your targeted treatment, or you can add capecitabine or olaparib in triple negative breast cancer. This is briefly a very, very brief overview. And there are newer agents that are coming up even in the HER2 positive space, which are drugs like Enhertu, which is now coming even in neoadjuvant setting, which is further increasing. If you look at the pathological complete response rates, in certain subsets, it is reaching as much as 83%. So imagine now a HER2 positive patient, which is ERPR negative, with chemotherapy and targeted therapy, 83% of these patients are not going to have any tumor on the resected specimen. And this again helps us in achieving good responses where breast conservation can further be planned. HER2 in ER positive, there have been remarkable advancements as well, but the standard adjuvant chemotherapy has remained the same. Here, a lot of de-escalation has happened. That means not all patients require adjuvant chemotherapy. There are several genomic risk scores like Oncotype DX, several clinical markers that can be used where chemotherapy does not add to any survival benefit, and these patients can safely omit chemotherapy. So this is very, very briefly about the kind of systemic treatments that is being offered depending on the subtype of the breast cancer. Thank you very much.
So actually what's happening, even if there is 7 centimeter size triple negative breast cancer patient, TNBC, then in the beginning, we are pretty sure that after chemotherapy, it's going to resolve or 1 centimeter size residual, and we can attain good aesthetic outcome along with the breast conservation. So this is how in even early breast cancer, it's helping, and borderline large operable breast cancers. I request Dr. Ekta.
Good evening, everyone. So just like all the modalities, radiology always goes hand in hand for any kind of treatment planning. In breast imaging particularly, the maximum advancements which we have seen over the last decade rather than 3 decades, where we moved from film screen mammography till 2015, we used to look at the view box, hold a handheld magnifying glass to look for any calcification or any non-palpable small masses. Everything changed when we had digital mammography. So the confidence of detection, estimation, disease extent, prediction was very poor with film screen mammography, and that we realized when we started using digital mammography, in which there was ability given to us for post-processing, for visualization, playing around with the contrast. Not only digital mammography, hand in hand came another tool or a weapon, we can say, was digital breast tomosynthesis. So basically, tomosynthesis is just like scan, we take multiple sections to the breast. So in addition to just detection, when we were having lesser confidence in looking for any additional lesion for dense breast, this tomosynthesis was helping us out by removing those layers one by one, so that now we are in better position to tell exactly where the lesion is. And this obviously comes in handy when we are doing tomo-guided biopsies or stereo-guided biopsies for non-palpable lesion. This all was complemented with advancements in the kind of ultrasound equipments which we were offered by the time we were reaching mid-2020s, where the resolution was much better. The equipments now had dedicated presets for elastography as well as for grayscale ultrasounds. So comprehensive BI-RADS assessment was possible for us. Even the additional lesion or surrounding ductal changes which were not very evident on mammography, ultrasound was able to pick up. Just when we thought that we have reached the peak of any kind of refinement, we got a very interesting tool, that is contrast enhanced mammography, and we have just become a fan of it the moment it has been validated. So what happens with contrast mammography is that we use the CT contrast, not the MR contrast. So iodinated contrast, you inject with pressure injector or hand injection, wait for 2 minutes, start acquiring mammography just the way we do mammography. And it gives images just pop up like within 10 minutes. So for patients who were eligible or being considered for BCS, initially had to wait for MRI, the dates and all those things. But now we were able to give the solution or some of the answers immediately. For example, if there is a mass causing nipple retraction, whether there is actually intraductal extension. So we were able to see the enhancement reaching up to NAC, which depicted that yes, there is nipple involvement. At the same time, it is able to tell us that there is ductal extension with satellite lesion, which was just seen as architectural distortion. So anatomical information was little bit limited, but the moment you add on contrast without uplifting or exhausting your resources of MR, we were able to see that even the contralateral breast, which had multiple circumscribed looking lesions, were cysts, but as well as an irregular lesion, which was malignancy. So picking up of contralateral lesion immediately changed the management. So this was kind of a path breaking for us whenever we talk about contrast mammo, and we have been able to establish that with the recent publication in which CEM shows 100% negative predictive value and sensitivity specificity reaching up to 97 to 98%. MRI still stays as problem-solving tool, even with the fact that we have abbreviated protocols, smaller duration protocols, but still our resources are not allowing us to use it for every patient, and it still is limited to certain indications. In that scenario, we tried to compare whether we'll be able to replace it with contrast mammo, and it actually helps us, and we're delighted to tell that actually CEM offers a very good solution, especially for the patients who need immediate decision whether the surgery is possible or not, and we have been able to offer MR in that, and this is all around diagnostics. When it comes to intervention, we all know that we have far away moved from palpation-guided biopsy to image-guided biopsy, especially for non-palpable lesion for calcifications. Now we offer vacuum-assisted biopsy directly whenever we are offering a patient stereotactic biopsy for smaller lesion, architectural distortion, or microcalcification. We do not offer them core needle biopsy. We have also moved into the innovation era where we have tried to develop CLIP in collaboration with IIT Delhi, especially for the patients who are undergoing neoadjuvant chemotherapy, because these are the patients who would later on need wire localization. We do not have that much population of non-palpable lesion as a primary onset. We predominantly have the patients who achieve complete response post-chemotherapy. And in the same setting, we offer hook-wire bracketing when we have two different clusters. So even in multicentric or multifocal disease, breast conservation can be offered with adequate radiological guidance. The newest offering which radiology is giving is targeted axillary node dissection. And the improvement with addition of ultrasound with the biopsy is that the efficacy and accuracy reaches up to 95%. The patient receives chemotherapy, achieves complete response at the primary site as well as the axillary node. And in low burden disease, the pathological complete response reaches up to 70%. So that means those nodes will not be palpable, and because of fibrosis, even SLNB will not be able to pick those up. And in that, if we already know that there were 1 or 2 nodes, we can put a wire on the day of surgery. So that comes in the recent most beyond breast.
Thank you so much, Dr. Ekta. And as we are doing seeing a lot of complete response, and there is need of clipectomy, so wire-guided localization is very important. And with the role of CM, we are detecting a lot of multicentric disease and that's why patients are landing up in mastectomies. So the entire treatment plan is changes over the different identification of multiple lesions. I request now Dr. Brijesh, Dr. Okay, for onco-anesthesia perspective, and without anesthesia, there might not be any surgery.
Thank you, Dr. Astos and the team. And on the behalf of Department of Onco-Anesthesia and Palliative Medicine, Dr. Gayatri will present our prospects.
Good evening, respected faculties. So as the surgical techniques evolve, it is mandatory that the anesthesia practices also evolve along with them. So briefly discussing the 30 years of anesthesia practice for breast cancer surgery at IRCH. So till 2006, the standard airway technique for all breast surgeries, that is general anesthesia with muscle relaxation and controlled ventilation, was practiced, and the pain management was largely based on opioid medications. During 2006 to 2015, as there was advent of the supraglottic airway devices, starting from the classic LMAs to ProSeal LMAs, and the most commonly used these days is the iGel LMA, has replaced the endotracheal intubation for the routine cases because of the advantages of smoother emergence, less coughing, and minimal postoperative sore throat. After 2015, there was advent of ultrasound in the perioperative care, which helped us with multiple facial plane blocks like the PEX 1, 2, serratus anterior plane block, ESP. These were adopted along with the general anesthesia for the flap and perforator-based breast surgeries. Also, the multimodal analgesia helped us in the early discharge of the patient. So this is the routine practice of general anesthesia induction, and the significant evolution has occurred in the securement of airway. As already mentioned, either the depending on the type of surgery, it will be either a general anesthesia with endotracheal intubation or a supraglottic airway device. So the difference is mainly in the LICAP, flap, and the robotic implant surgeries, where we still require endotracheal intubation. Why? Because of the long and meticulous dissection, which prolongs the duration of operative time, and the steeper head-up position required in the robotic breast implant surgery. So these positionings causes a risk of displacement or seal loss if we are using a supraglottic device. So we still use the endotracheal intubation. So another important change that we have noticed is we have started using the facial plane blocks. There are 7 options, but most commonly used are the erector spinae plane block, the serratus anterior plane block, both the deep and the superficial ones. As mentioned, we are more towards the multimodal analgesia plan, which includes paracetamol, non-steroidal anti-inflammatory agents. Opioids have been reserved only as rescue analgesics, and this has been helped by the regional block that we give at induction of anesthesia. Along with analgesia, we also have to take care of the post-operative nausea, vomiting, which is not optional. So we are following a 2-drug approach, that is either ondansetron 0.1 milligram along with dexamethasone at induction. So multiple research has been published from our department in this respect. So we tried to compare the effect of pregabalin on chronic post-mastectomy pain syndrome, which is a very prevalent complaint. But we could not find much difference in using pregabalin preoperatively throughout the post-operative period. Then there were 2 studies comparing the serratus anterior pain block along with the general anesthesia, either using a local anesthetic or along with a dexamethasone adjuvant. So both have shown that adding the block along with general anesthesia halves the requirement for rescue analgesic dose, and adding a steroid halves it again. Another study which has compared the erector spinae and the paravertebral block, again both provide identical analgesia results, but as ESP is quicker and lands in first attempt success rates, so it is preferred for these surgeries. Again, a paravertebral block compared with a complete antithoracic block. So again, these blocks have shown lesser pain scores at rest and as well as on the movement. There was another study, that is the effect of regional anesthesia on immune response, recurrence, and metastasis in breast cancer surgery. So this has showed that there is better preservation of postoperative immune cell counts in the erector spinae vein block when compared to the control group, particularly in the CD4 T cell and the NK cells, which suggest a reduced immunosuppressive effect. Thank you.
Thank you so much, and we are always grateful for our onco-anesthesia department, Sima ma'am, and all colleagues. Without their support, it's very difficult to run any such kind of program. So in next 15-20 minutes, we are going to bit fast because there are a lot of changes in the surgical pattern and the advancement. So in phase 3, 2015 onwards, we have seen about the routine sentinel lymph node biopsy, improved BCS rates. And this time, this is the era when we were thinking of aesthetic surgery along with the oncological outcome. So if we are thinking with the concept of aesthetic surgery about the breast size, shape, symmetry, then as an aesthetic surgeon, I am happy. But as an oncosurgeon, I am not happy. So it's very difficult to balance both oncological and the aesthetic outcomes. So pathway that we have drawn is the mastectomy or breast conservation. If you are going for mastectomy, then it's with reconstruction or without reconstruction. And breast conservation, then level 1 oncoplasty or level 2. Level 2 is the volume replacement. So this is the guy, Mustafa Hamidi, in 2004. He developed and he discovered the pedicled perforator flaps. So what are these perforator flaps? Usually we can heard these names like lateral intercostal artery perforator flap, anterior intercostal, MICAP, LTAP. So this is the, so here from the vertebral side, there is an intercostal vessel, and wheresoever they are perforating, they are supplying that skin island, and that's we are using for reconstruction of breast. And this is the area. So most of the time, these perforators are being localized by the Dopplers because these are 1 mm or 2 mm in size. And it's sometimes when patient is bulky, then it's very difficult. So we use these Dopplers to identify, this is the LICAP perforators. This is anterior intercostal artery perforator. But in a bulky patients, it gets difficult. So these are the aesthetic outcome, right? BCS with LICAP flap. They gives ultimate symmetry of the breast, good volume, and a hidden scar. So this is 21-year-old female, and she's unmarried, and we planned for a breast conservation and large size breast tumor. So you can see there is almost hidden scar, and she has received the radiotherapy, and after radiotherapy also it's able to maintain the symmetry. So for last 15 years, 2004 till 2019, the entire focus was on the Doppler based development of these perforator flaps. So first time I did this procedure in the NCI when there was no Doppler support or frozen support. So we need to excise a large volume, and we have given the concept of no Doppler single position like a flap. And on the basis of the landmark only, these are the fixed area where are the perforators are available, we can harvest these flap and reconstruct the breast. Similarly, here most of the upper outer quadrant is involved, and on the basis of this flap only, you can from the same incision, you can address the axilla and the lumpectomy and can fill the entire defect. So particularly in partial breast reconstruction where luminal A is present and poor tumor breast ratio where chemotherapy is not going to work. So sometimes either patient will end up in the mastectomy or you can conserve by doing those perforator. So on the just on this minute perforator, you can harvest the flap up till spine. This is the one of the largest flap that we have harvested in spine, and we reconstructed the breast. And these are the pictures after 5 years. Patient is doing well. So these are the robust flap, and you can be in our setting, and being a tertiary center, we see a lot of post lumpectomy patient, and the margin positivity rate in these patients are around 30%. So when the patient is coming with the scar and you are not sure about the margins, then how to replace this defect. So it's very important that with the help of these perforator flaps, you can fill these defects and can get good aesthetic outcomes. Whenever there is large defect, LD is the option, but we can avoid LD also. So this is the different scar, and we can preserve the breast. And only on the mammogram, you can follow up all these patients. This is another thing. medial intercostal artery perforator flap. So the medial most part is there is a very less fatty tissue, and any defect cause a disfigurement. So it's very difficult. And again, we have this standardized this technique and published this no Doppler MICAP flap. So any defect in the medial quadrant as well, we can take the flap from the lower side and can fill this and can achieve the outcome. So we have a standardized without any Doppler, you can just follow the principle and can get good aesthetic outcome. We have published our techniques and follow-up principles in different books and all these things. This standard LD flap we can harvest for the reconstruction. So oncoplasty, if you see after 2013, there is a gradual enhancement, and this is the type 2 oncoplasty, perforator flaps and all those things. After 2020, we have advanced, and we have done more than 200 perforator flaps at both the centers, and ICG-based sentinel lymph node biopsy. After 2015, there is a routine of indocyanine green for the sentinel lymph node biopsy. This is the first system that we acquired, Novardex system, then SPY-5 system for. So this is the real-time assessment, navigational surgery. You can identify the lymph nodes and you can take out. So even in the post-NSCT setting with the dual dye, we can take out the good chunk of lymph nodes. And we have this standardized our technique by the dual type, and accuracy rate was more than 97%. So coming about the whole breast reconstruction, because in India, we are seeing a lot of young patients coming with the multicentric disease where the requirement of the mastectomy. And in those patients, there is no option of autologous reconstruction because sometimes you need to go for bilateral reconstruction because they are BRCA1, BRCA2 positive. So such kind of defects usually created after the tram flap when we harvest the tram. So particularly, these are the indication for the whole breast reconstruction, multicentric disease, diffuse microcalcification, risk-reducing surgery. Now, a lot of patients after 2013, when the insulin, she detected as BRCA1 carrier, and then she underwent bilateral mastectomy and the reconstruction. Then there was a lot of change in the world breast surgery spectrum. So in 2015, we started a study to just map the landscape of an understanding of the patient about the genetics. And we found after assessment of 300 patients, none of the patient was ready for risk-reducing surgery, although they were ready for active intervention. So we have done this study, and then in the familial clinic that we have set along with the Dr. Raja, we have gone for a lot of understanding about the familial cancers. And again, with IGIB and CSIR, Indian Breast Cancer Genomic Atlas, we gathered the whole gene sequencing data of around 500 patients, second largest in the world after TGCA. So this is how this genetic program after 2015 evolved. And in last year, ESCO, there was the survival advantage they have seen. So as of now, after 2017, we have done almost 90 risk-reducing surgery till date, and with bilateral breast reconstruction. And as we are seeing bilateral breasts, so again, we published our data. Mastectomies gradually after 2015, number increased, and last year we have done around 40 plus implant-based reconstruction. So NSM benefit is aesthetic outcome, patient satisfaction, and psychological impact. Secondly, there are a lot of literature currently available about the safety of NSM. Now it's fully safe, and we are sending margin of each and every patient. There are also some high-risk patients, and where smokers are present close to NSE and obese and large breast. So implant-based reconstruction, you can place implant either behind the pectoralis muscle or in front of the pectoralis muscle. So you need to understand when to place the prepectoral and when to place the subpectoral. So in our situations, when the patient is distant, cannot come for frequent follow-up, we usually place implant behind the muscle, and the skin quality is not good. So that's our choice. When the patient can come up for frequent follow-up, then definitely prepectoral. In prepectoral, there are larger perioperative complication, but the quality of life in the long run is very good. In subpectoral, there are less perioperative complications, but long-term quality of life is bit inferior. So this data is presented this year in the ESCO. So this is the concept. It's very important to understand because there are only 3-4 centers in India who have done more than 100 implant-based reconstruction. Because the entire flap supply, when you remove the entire gland, the entire flap supply is coming through this small vessel from both sides, inferior and superiorly. The entire supply from this has gone. So larger the flap, larger the breast size, there are the high chances of complications, high chances of NSE necrosis. And similarly, In open NSM, these all nerves are damaged, so there is highly 0 to 20% chances of NSE sensation. So currently we are using silicone implant, round, and nano-textured or smooth implant. So these are the different size. And we have to understand about proper fitting implant. So marking is very important in all these breast cancer patients to select proper fitting size implant. So this is the ADM mesh. In last 10 to 12 years across the globe, there was a standard that we need to place implant inside a mesh, just like ADM. This is acellular dermal matrix from the bovine spine. It's a collagen scaffolding, and the tissues grows inside this. So we wrap implant inside this, and we are the center that we have done maximum number of cases in India. So here, if you see, this is the ADM. Then we worked on the composite mesh that used for hernia, then simple vicryl mesh, then patient own tissue dermal sling lower half, then subcutaneous implant. So we are the only center currently in India who is doing subcutaneous implant. And then for large breast, WIV flap. So we have done all the flaps, and our results are almost similar. So with the help of ADM, you can see there is almost symmetrical breast, and long-term follow-up, there is no rippling, there is no changes in NSE and all these things. Even in post-BCS RT cases, we have done the implant as a second surgery. There was recurrence. Where NSE is not cannot be preserved, then we can go for SSM and then post-mastectomy tattooing. This is ADM, how we stitch. Already stitched ADM, a prepared pocket cost 1 lakh, more costlier than the available one. So this is implant, and this is how we wrap the implant. So this is the young patient, 28-year-old, underwent implant-based surgeries, and these are the. So ADM cost is 1.75 lakhs, implant is 30 to 40,000. So this is a huge burden on the patient. So for the distance that we have discussed, that subpectoral implant, we have done this synthetic hybrid mesh, and we have published our technique with the help of hernia mesh, and we get good results. And our experience with the low-cost meshes, this is a simple vicryl mesh. And in this patient, this is preoperative picture, and this is just after placing the vicryl mesh. So almost the cost is reduced by 90%. This is vicryl dual layer mesh. We wrapped it double. So this is the pre-op and post-op picture. And this is subcutaneous implant. So directly we are placing the implant below the flap, under the flap. And these are the post-op picture, bilateral. This is the robotic NSM, and these are the pictures. So this is large breast, large ptotic breast. Can we do implants? Yes. Here in this patient, we need to reduce the skin. Along with there is the shifting of NSE. So it's a bit challenging. So the entire supply of NSE depends from the superior pedicle and the inferior pedicle. So it's very limited, and the high chances of necrosis if it's not done meticulously. And entire lower half of the skin goes inside, and NSE goes upside. So this is called wide-based flap. And so this is how you dissect the entire blood supply is gone. And this is the halo defect that you see, and your manual supply is coming from here. Then this is the placement of implant with the ADM. And then again, you shift the nipple. So this is the pre-op, and this is the post-op picture. Similarly, the same procedure with the proceed mesh, the same way you do the mastectomy, you preserve the supply, and with the help of this proceed mesh, the implant is placed below the muscle. And this is the muscle, pectoralis muscle, this is the proceed mesh, and you can get good, robust outcomes. And this is autologous complete flaps. Even the larger breast, where you need to shift the nipple to here, and the lower half of the breast flap that used for the covering. In this, we have taken out the nipple and placed as a free NSE transfer. So the nipple has been taken out. And this is the lower half of the breast flap that we have used as a mesh and covered the implant. And this is the preparation of nipple, then stitching of nipple, and these are the post-op outcomes. Similarly, in young patient where we don't want to go for any visible scars, so you can place a IMF incision, can do mastectomy from that incision, 5 centimeter size. Then this is a parachuting. You need to place a very focused and suture so that that will align with the opposite side of the breast. So these are the post-op pictures of those patients. So hardly visible scar, almost symmetrical breast, and over 1/3 of the patient has gone under radiotherapy, and all of them are doing well. I'm very grateful to the radiation oncology department. And as of now, we have 0 explantations. 100% of our breast patients are doing well. Worldwide is 5%, 5 to 12%. Now we are pushing our boundaries, more focused, more precise. It started in 2016. As of now, we have done 16 cases. It's all established as a quality of life and short-term oncological outcome. In the department, we have given one thesis for conventional versus robotic NSM and the outcome. And this is the pictures and all the safeties and all these things. So currently, robotic surgeries in T1, T2 tumor, cup size A or B, around 1 centimeter. We have tried in cup size D, and our patients are doing well. And this is the robotic setup. And this is the patient, 400 cc size implant with 6.5 centimeter incision, and patients are doing well. This is pre-op, post-op pictures, cup D size breast, and this is the homogeneous picture. Here you can see the light, the flap thickness, and NSC is preserved. So it's just a glimpse inside the breast after robotic surgery. Here you can see the flaps. This is the posterior wall, sloping edges. This is the perforators going. Your entire thing is safe. This is our another technique that we are publishing for the malignant tumor in the central quadrant, how to address them and how to get optimal outcomes. So here if you see, so this is the NSC region. Shit. So this is the NSC area, and you can precisely cut the ducts, even if the tumor is 0.5 centimeter or 1 centimeter close to NSC, even then also you can go in those area and can take care of. So this is entire fat is removed, and always we send frozen as a NSC margin as a frozen. So these are the hardly hidden. Another important thing that we have seen 70 to 100% NSC sensation, which is never feasible. So we are giving a live breast to the patient, and this is the ducts, and entire thing is removed. And these are the aesthetic outcome. So hardly any visible scar with good quality. And another thing is NSC sensations.
10.
So these are 10 out of 10.
10.
So we have developed this assessment model, different zone-wise, in which zone the patient is developing, and we are about to publish this. So this is sensation. In open conventional surgery, it's never possible to attain such kind of NSC. So we are giving live breast to the patient. Recently, we have done the first Southeast Asia's robotic workshop, attended by more than 100 delegates across the world. And we have launched this robotic breast surgery book. And Dr. Antonio Toesca, he is the first person who has done robotic breast surgery. He is the pioneer. And I came to know that this book is the first in the world as a comprehensive textbook of breast surgery. Other textbooks that we have published, Dr. Dev, breast oncoplasty, Dr. Ekta and Dr. Dev. First oncoplasty workshop conference we have done in 2018. And this is the first workshop, cadaveric workshop. Every year we are doing oncoplastic workshop on cadavers, and last 3 years, we have trained more than 300 delegates across the country, and also on robotics. We are also working on the AI, integration of AI in breast cancer surgery with the ESCO. And these are our some benchmarks: mastectomy 58%, BCS 42%. BCS in early cancer, we have achieved around 79%, 96% in early EBC, SLNB. And in post-NSCT setting, even in 59%, we are doing SLNB. Margin positivity 1.6%, lymphedema 7.8%, and risk-reducing surgeries like this. So we have done a lot of publications, thesis, and the projects, and our activities are being endorsed by different societies across the world. And so this is very important. The outcome that has not been optimized in Indian breast cancer is not on the Kaplan-Meier curve. It's the one the women see in the mirror at 40 with 40 years left. So this is very important. I am very grateful to my department and all colleagues, residents, and allied specialties for contributing and running this program. Thank you so much, sir. I request from you, sir, for the concluding remarks.
Thank you, Ashutosh. So everyone must be, have realized that we have come a long way. So this is something, a journey which keeps, evolving all the time. More and more, the breast, either surgical advances or for that matter, multidimensional advances from different specialty. So that's the true example of having a precision medicine as well as personalized medicine. You show me the patient, I'll show you the treatment, not only the medical, not only the radiation, but also the surgical. Thank you very much. Now the house is open for the further discussion. But before that, just one snapshot I want to show you. Whatever we have talked about, that comes from a centralized database. And this is something which is the workhorse of the communication, development, as well as quality check for the entire department. So this is where you can get your results within a matter of 5 to 10 minutes. You tell me that which question you want to answer, and as much as comprehensively possible. And this is something we really take pride in that, and this is maintained not by a data entry operator, but by involvement of each and every resident as well as faculty. So with that, I thank you all for coming here. Now, if there are any questions, then certainly we will be happy to take them up. Maybe Dr. Chumba sir will word the comment.
Okay, I must congratulate all of you today because you have come a very long way. Breast clinic was started in Department of General Surgery by Professor B.M.L. Kapoor. And in fact, he was the first chief of the IRCH. And Dr. Shukla moved from the Department of Surgery to Surgical Oncology. And I was a senior resident in Surgical Unit 1, and I trained with Dr. L.K. Sharma, who at the time of his retirement had done over 2,000 radical mastectomies. But I didn't want to become a breast surgeon. I wanted to do endocrine surgery, but my colleagues took up breast and they moved rather far with that. I continued to send all my patients to Dr. Shukla in Cancer Hospital, and then to Dr. Dev and Dr. Sunil. You people have come a very long way since then. And the Department of Surgery itself has continued with its practice of breast cancer and its treatment. I see all the faces here who are helping us in the surgery block. And you can see at least one of our surgeons is here. So once again, I think big claps to all of you. And continue to do with it. And I think we should get together on all of this. Thank you so much. Thank you, Sunil and Ashutosh.
Thank you, sir. We are grateful for your comments, sir. Once again, thank you all of you for coming and participating in this CGR. Certainly, this journey goes on, and with support of the multiple departments, as well as the radiology, pathology, onco anesthesia, radiation oncology, medical oncology. So it's not that we are here to thank them. They are all our partners in the whole program, but then it also gives us a realization that the whole system moves because of the multiple chains, which are all of them are equally important. And there cannot be a better example than the breast cancer program, which runs entirely on truly a multidisciplinary fashion. Thank you very much.